Well, hello. Now we're back and we're going to be doing Lab 5. This is focused on the axial skeleton. Includes exercises in your exercise lab manual, the Seracus book, from 7.6 to 7.14. Well, let's get started. Now, in this situation, you are going to review 7.6 through 7.14. If we were in a lab, we would be using, of course, the skeleton, disarticulated bones. Disarticulated bones means basically they're separated from the basic skeleton, so you can examine them one at a time. We're going to mostly focus on lab manual diagrams, but there are some excellent videos, and I strongly urge all students to view them for the lab videos for this particular lab, because some of the instructors are actually going to go through those same disarticulated bones, going over parts that are essential, including not just what the bone looks like, etc., where it's located, but also the bone markings. Okay? Now, you're going to complete the review sheet at the end of exercise 7, which will include pages 107 to 110. Well, I've already set that up for you. It is in a PDF form. You need to complete it. This will not be a bad thing to do, because sometimes redundancy enhances recall. Now, make sure when we're going through all of this that you are reviewing the bones, but also the bone markings, okay, on each and every one of those bones, because you've got to comprehend the function of these markings as well. They are going to be coming back to you time and time again as we go through the muscular system, we go through the nervous system, we go through the circulatory system, etc. Okay? Now, the handout that's due is due on Friday. Yes, Friday this week, 5 p.m. And it shouldn't be that hard by now, because you've been able to fill out these PDF forms and then put them up. And this will enhance your learning. Okay, let's get moving. As you can see, we're going back to that same table here about the various bone markings. I encourage you again to review those. For example, those that are projections that are sites of muscle or ligament attachment, tuberosity, crest, trochanter, line, tubercle, epicondyle, spine, and process. Now look at various bones have various structures that are going to be attached to muscles, ligaments, tendons, etc. You really need to get these down. Okay. Also, they do have interaction with bone to bone, such as with the vertebrae. Vertebrae above and vertebrae below are interacting with the vertebrae. That's your focus one. Surfaces that help form joints include head, faucet, condyle. Depressions and openings. As you can see from just the skull alone, there's quite a few: groove, fissure, foramen, notch. Also meatus, sinus, and fossa. It's not just a matter of understanding what they are, but the fact of where they are on the skull. Okay? The anterior orbital fissure, you have the foramen. All of these are absolutely essential. Okay? So I strongly encourage you to go through all of these now. When we talk about the axial skeleton, that consists of all bones that form the vertical axis of the body. These include skull. Now, there are a couple of other unique bones that not everybody gives attention to, but they are extremely important. The hyoid, which is not really attached to anything else, any other bone. It's around basically where your larynx is, okay? And we'll see this as we move forward. Also, the auditory ossicles. These three tiny little bones that you will see in the middle ear play an extremely important role in the conduction of sound and the conversion of it to eventually what will be nerve signals for the auditory sensory system. Vertebrae, which play a key role in protecting, such as the lungs and the heart, etc. No, excuse me, let me scratch that. The vertebrae play a key role as attachment for back muscles, and also the protection of the spinal cord. It is the ribs that are protecting such structures as the heart and lungs. I'm sorry about that. And then, of course, you've got the sternum. Now, the skull is the key protection for the brain and other sensory organs, such as what we're talking about, the eyes, hearing, balance, So when hearing imbalance, we talk about that as the vestibular and cochlear. That of the tongue, so the sense of taste, as well as olfaction. Olfaction is the sense of smell. Okay. Now, bones of the anterior view. So in other words, what we're talking about are structures in the frontal facial area. These include the frontal bone, the nasal conchae, which is the superior, middle, and inferior. The superior and middle structures are ethmoid bone, and the inferior is a separate bone. Then we have, of course, the nasal. We have the maxillary bone, zygomatic bone, mandible, and of course the nasal septum, which is partly made up of the ethmoid bone and partly made up of the volar bone. Now, if you take a look at this from an anterior view, you're going to see the bony orbit. That's what we have, where the eyes are located. But that orbit is not just like one big single bone. It's actually a composite comprising frontal, ethmoid, palatine, lacrimal, maxillary, sphenoid, and zygomatic. The bone markings that you need to really get down cold, hard, and fast are the optic canal, infraorbital foramen, mental foramen, supraorbital foramen, and superior orbital fissure. You can see all of these well set up here. Here's, of course, the facial bone area, the anterior view, and you can see the parietal bones, the frontal bone, sphenoid, ethmoid. Notice that they're color associated, so it helps you. Then we have, of course, the nasal bone, the lacrimal bone, palatine, zygomatic, maxillae. That's the upper part here. Yes, it also includes the area where the upper row of teeth are. The inferior nasal conchae, which is down here. And then, of course, we have single bones, the volar, and then we have this lower, which we call the lower jaw, the mandible. Notice that there are some significant bone markings here, okay? We'll get into those in a minute. Now, when we came up to the orbital, we had to bring up this. We had the lacrimal fossa, the supraorbital margin, the supraorbital notch, the frontal bone. Notice down here we have the palatine bone, the ethmoid bone, the lacrimal sulcus, the nasolacrimal canal. Notice down here you can see a little bit of this. These, by the way, these shelf structures called conchae, really what they are is where epithelial tissue lies over in it. And as you breathe in, you sniff, and I have some roses in front of me right now. I'm at a vacation spot, and there's a nice table with beautiful roses, and I can go sniffing it, and this causes currents and turbulence in the nasal cavity that allows me to pick up the different scents that would make the fragrance of roses, because what's going to happen is we'll have olfactory epithelium lining and sort of being around these areas of the conchae. Let me move forward. We're going to have the maxilla bone down here, the infraorbital foramen. The zygomatic facial foramen is right here. This is the zygomatic bone. We have the temporal bone here. And then you can see how some of the bone sort of appears a little bit and then disappears and is on the inside here, and that's the sphenoid. The sphenoid. Okay? Now, a couple of interesting things you want to keep in mind. If you look on the lateral view of the skull, you're going to find that many bones form what's called the neurocranium and are fused together by sutures. The lateral view bones consist of the frontal, parietal, temporal, and sphenoid. The bone markings include, and yes, you need to know these, cold, hard, and fast, the coronal suture, squamous suture, external acoustic meatus, the mastoid process, and the pteron, which we also would call the temple. Now, bones of the lateral view also include the facial bones, which are the nasal, zygomatic, maxilla, and mandible. Now, bone markings on the mandible, really important. The coronoid process, teeth, alveolar process, mental foramen, body of the mandible, ramus of the mandible, mandibular notch, and the condylar process, right? So here you have the mandibular angle, You have the alveolar part of the mandible. Here's the mandible bone as a whole. You have an interesting thing that comes up. We have the zygomatic bone here, and this is part of the temporal bone. Notice that they come together right here. We kind of call it the cheekbone. Now, zygomatic process of the temporal bone is on this side. Temporal process of the zygomatic bone is on this side. Okay? Now, you can see here, obviously, the parietal bone, occipital, temporal, frontal. You will see some of these other structures here. This is the sphenoid, but you'd see more of it on the inside. Of course, you're going to have some of the ethmoid, the lacrimal bone, the nasal bone here. You have the maxilla here, which includes the alveolar process here. All right? If you take a look down here, where we look exclusively at the jaw, okay, the mandible. You see where the teeth are. We have the alveolar part of the mandible. This is the insertion site where you would have teeth that develop and are out, come out there. You have a mental foramen here. This is the body. The mandibular angle right here. You have, of course, the ramus here, the mandibular notch here, the condylar process. This is where we get into where it comes into and attaches up here in the skull, the TMJ joint, temporal mandibular joint. And then we have this extension up here, which is called the coronoid process. All right. Now, what about the posterior view? Bones of the posterior wall of the neural cranium include occipital and parietal. Bone markings on the posterior view include sagittal suture, lambdoid suture, supranuchal line, which is a superior limit of the neck, and the external occipital protuberance. You have to think about this. How do we attach the head to the neck? Well, we have to have some structures that can grab on to these areas in the back, which would include these special structures right down in here. This is the occipital bone. You can see the lambdoid sutures here and here. You see the sagittal suture, and yes, you'd have to know, well, the sagittal suture basically is the boundary between the left and the right parietal bone, okay? And the lambdoid sutures are the boundary between the parietal bones and the occipital bone, all right? Now, base of the skull, this is the inferior view. This is where you look upside down, you look down into it, and you can see all sorts of bone markings. You also have, if you look into the base of the skull, from the inside, the neurocranium side, where it's protecting the brain, you're going to have a lot of very important markings too. But let's go through this. You look at the floor of the cranial cavity, you have the hard palate, which is composed of the palatine process of the maxillary bones and the horizontal plates of the palatine bones. Bones of the base of the cranial cavity include vulnar maxilla, palatine bone, frontal bone, zygomatic bone, sphenoid bone, temporal bone, occipital bone. Major portion of the base of the cranial cavity is composed of sphenoid, temporal, and occipital bones. And if you look at the diagrams, you'll be able to see where I'm pointing out here. The base of the skull, this is from the inferior view, the bone markings that are key are the following. Foramen lacerum, this is between the temporal and the occipital. Foramen ovule, this is the sphenoid. The carotid canal, this is the temporal. Is that where the carotid arteries come in? Yep. But we'll get into that. Jugular foramen, between the temporal and the occipital. That's where the jugular vein brings out blood from the brain. The stylomastoid foramen, this is between the styloid and the mastoid process. The foramen magnum is the base of the occipital bone, opening for the spinal cord. Okay, so it's foramen magnum. Think of it as this way: the large magnum. Magnus is being seen the biggest. Okay, I've already talked to you about the zygomatic arch, part sphenoid, part zygomatic, and then we get into the styloid process, which is part of the temporal bone, the mandibular fossa, which is temporal and joins with the mandible. Okay, and then the mastoid process, which is the temporal. Now, bone markings at the base of the skull, the inferior view, also include the occipital condyles. These are occipitally joined with the first vertebrae. These are sort of like little pads. So you have this point where the skull. Furthermore, you will also notice that there are a couple of very special pads on C1, the cervical vertebrae. These come in contact with the occipital condyles. Now, inferior and superior nuchal lines. These are part of the occipital bone, and they basically are attachment points for tendon, for ligament, etc. So basically it allows you to basically have your head effectively attached and moving around at the top of the neck. The external occipital crest is also extremely important. I encourage you to take time to review that. Now, here's where we see everything. Okay, here's the external occipital crest, the inferior and superior nuchal lines, okay? And you see all of the bone markings here. Of course, you've got the lambdoid suture. This is mostly the occipital bone, okay? And you have basically forema of the sphenoid. Around here, you have the foramen lacerum right there. The foramen ovule right over here. The temporal bone is right here. Here's your styloid process right here. Okay, so really right nearby it should be the stylomastoid foramen. And of course the carotid canal. Over here is the jugular foramen. I made a mistake here. I'm just going to clarify that right now. The stylomastoid foramen is that tinier one. The larger one is the jugular foramen, where the jugular vein comes out. Okay? Obviously, this huge foramen is the magnum one, where the spinal cord would come out. Okay? These are the occipital condyles. And as you can see here, you have the hard palate up here, which is consisting of the maxilla, the palatine bone. The soft is more cartilaginous and it's back here. But what you can also see nicely here is the vomer bone. You can also see where the zygomatic bone is. This is the zygomatic arch, okay? And part of this continues with the temporal bone right here. All right. Now, let's move forward. The cranial cavity of the skull. Now, this is where you get the neurocranium, okay? Bones of the floor of the cranial cavity include frontal, ethmoid, sphenoid, temporal, and occipital. You need to know that there are 3 depressions or lower areas in that cranial floor. The anterior is room for the frontal lobes of the brain. The middle is for room for the temporal lobes of the brain. The posterior cranial fossa is the area where you would find the cerebellum and the brainstem. Now, excuse me. On the inside, you've got a lot of markings here that are very important because they are usually sites for some of the structures of the brain, as well as cranial nerves coming in and out, and blood vessels coming in and out. So let's go through some of them. The greater and lesser wing of the sphenoid, you will be able to see. In the sphenoid, you would see the sella torica, which is kind of like a little satellite structure, but it's the site of the pituitary gland settles in. You have an area for the optic canal in the sphenoid, the foramen rotundum in the sphenoid, the foramen ovule in the sphenoid, the foramen spinosum in the sphenoid. Excuse me. Now, the crista galli is an important point in structure. It is on the ethmoid. It is the attachment for the falx cerebri, which is a membrane on the brain. It's part of the dura mater. which allows to keep the brain from shifting around inside of the neurocranium. You have also, of course, the carotid canal, which is part of the temporal bone, the internal acoustic meatus. Now, the external and internal, basically what this is a pathway that where you have sound waves come in, you have the external ear, the middle ear, and eventually you have the inner ear. And from the inner ear, you have these nerves that pass through both the vestibular nerves and the cochlear nerves that eventually come through. And this will come out through the internal acoustic meatus, and eventually it will be processed both by the temporal, which will process acoustic sound. Balance will be processed by several of the sections of the brain. Hypoglossal canal is part of the occipital. So if we take and look inside, here we have it. We have the frontal bone would be out in here. We have the crista galli here. This is sort of an anchoring site. And on each side are these nice little fine holes. This is part of the cribriform plate, and this is where olfactory nerves pass through and go and basically form the olfactory epithelium inside of the nasal cavity. You have the sella torica here. So right where my pointer is located would be where the pituitary gland would be. If you look at the sphenoid, you have, of course, the space for the optic canal, foramen rotunda, foramen ovula, foramen lacerum, and foramen spinosum. The temporal bone will have the, right over here, the carotid canal, lines are all over the place, so it's kind of hard to pick some things out. And then the internal acoustic meatus, which is coming out from here. Now, what you have on the occipital bone, at the sort of the boundary between occipital and temporal, is this site for the jugular foramen. And then you have a hypoglossal canal, which comes out right out here. And then, of course, the foramen magnum right here. The internal occipital crest is right through here. All right? Now, the sagittal section of the skull. When we look at this, this is going to include the bones of the frontal, parietal, occipital, temporal, sphenoid, and facial bones. The facial bones will consist of the mandible, maxillary, palatine, vomer, nasal. The bone markings include the paranasal sinuses, the frontal and sphenoidal areas, the nasal septum, which is composed of a perpendicular plate. Now, this is important. You need to understand that this is part of the ethmoid bone as well as the vomer bone that contribute to this nasal septum. The hard palate, which is composed of the maxillary and palatine bones, and then, of course, the sutures, which include the coronal, squamous, and lambdoid. I've mentioned already about the sella torica and the hypophyseal fossa, which is a space for the pituitary gland. And you can see this right here. So here's the fossa, the hypophyseal fossa. So right in here would be the pituitary gland. Why we're taking a mid-sagittal cut, so you can see where some of these spaces are. The sphenoidal sinus is right here. You have the frontal sinuses here and here. You have, obviously, of course, you've got this inferior nasal concha here. You have the nasal septum right here. This part is ethmoid. The lower part here is going to be the vomer. Here you have this part being maxilla for the hard palate, the latter part here for the palatine bone. The hypoglossal canal is over here, so that's part in the area of the occipital bone. You can see where the internal acoustic meatus opens up here. Notice the sutures: lambdoid suture, squamous suture, coronal suture. Okay. Here in the blue, you can see very clearly this is what the sphenoid. Sphenoid and ethmoid are kind of tricky, and that's in part because they're mostly internal. They're hard for some individuals to picture at times. Okay, And of course, you've got the styloid process down here. Now, there's something that you have to understand is that in fetal skulls, you have you've got a lot of active growth, you've got remodeling that accommodates the brain growth and allows flexibility of the skull so that it can pass through the birth canal. At birth, ossification is incomplete. You have adjacent cranial bones that are connected by fibrous connective tissue. This is where you get into the formation of the fontanelles. These are fibrous regions, soft spots. These include, of course, the anterior, which is in the frontal area of the bone, posterior, which is occipital, sphenoidal, which is the anterior lateral, mastoid, which is the posterior lateral. The bone markings you need to note are smaller, less prominent than those of an adult skull. So when you take a look at, and you see this as you go from the progress of 3 months fetus to a newborn, and eventually to an adult, all of this blue material, which makes up the fontanelles, will eventually be ossified, and you'll have the fusion here. For example, in this image right here, this top-down image, these frontal bones will come together, fuse. The parietal bones will come together and fuse, and they will form the suture. That's where we get the sagittal suture. You have also the occipital back here, but notice the spacing here. Same thing as if you looked at the parietal bones here and the frontal bones here. Notice that there is a lot of flexibility here. This is allowed at the point of birth. Afterwards, you still get some of this calcification, replacement of the fibrous tissue with more bone tissue, and then you have the formation of the sutures, the fusion between the two bones, here and here and here and here. And this is extremely important. Now, we're going to talk about a couple of the very unusual bones. Hyoid bone. It's a U-shaped bone situated at the root of the tongue, in the front of the neck, and between the lower jaw and the largest cartilage of the larynx, which we would also call the voice box. The primary function of the hyoid bone is to serve as an anchoring structure for the tongue. The other major bones that we need to be aware of are the auditory ossicles. They're also called the ossicles. There are 3 bones that are in each of the middle ears, okay? And they are some of the smallest bones in the body. They serve to transmit sounds from the tympanic membrane, the eardrum, to the fluid-filled labyrinth, which we call the cochlea. We'll get more into this later on in a subsequent chapter on the special senses. But here they are. If you look at this, these are the actual shapes. Compare that to the hand that's holding this little. This is one of the convenient demonstration tools. You'll see the malleus, the incus, and the stapes, which otherwise is referred to as the hammer, the anvil, and the stirrup. And you can see where they're located, right in the middle area, the middle ear. Here's the hyoid. Now, why it seems to be so interesting is because really it is an anchoring site, but it doesn't attach to any other bone. If you look at a skeleton, you can tell a good skeleton. Why? Because if you look just underneath the jaw, you'll see that they have a couple of wires attached. They sort of wired it somewhat to the vertebrae, but it's not really attached to the vertebrae. Poor skeletons do not include a hyoid, or that the hyoid's been removed. You can see on the edges here the greater horn, the lesser horn, and the body of the hyoid bone. Now we're going to go through the vertebrae. The vertebral column supports the head, neck, and trunk. Vertebral regions and normal spinal curvatures you need to be aware of and get familiarized with. When we talk about vertebral regions, cervical vertebrae are 7 of them, thoracic are 12, lumbar are 5. The sacrum is consisting of 5 fused vertebrae. The coccyx, tailbones, consist of basically 4 fused vertebrae. The way that they designate the different vertebrae is with the first letter. So cervical, they would say cervical C1 through C7, thoracic T1 through T12, lumbar L1 through L5. Sacrum, you just call it the sacrum. The cocci, though, they will probably call it C0. Now, if you want to get really specific, they will include S as S1, 2, 3, 4, 5, even though they're fused. So you want to keep that in mind. The coccygeal is referred to, so it's not to be confused with the cervical, is CO, and it's just usually CO1. There are two primary curvatures. The primary, which is a concave surface faced anteriorly, and that's in the area of the thoracic vertebrae and the sacral. The secondary is concave surface which faces posteriorly. You'll find that in the cervical and in the lumbar. As you can see here, here's the cervical curve, this is the thoracic curve, here's the lumbar curve, here's the sacral curve. Here are the numbering of the vertebrae, C1 through C7, T1 through T12, L1 through L5, sacral, coccygeal. You see how the coccygeal is just kind of like a tip at the edge. Actually, in certain developmental defects, there will be children that will be born with a little bit of a tail, and surgeons remove that after birth. Okay, but it's a rare 1 in 1,000 or 1 in 10,000 situation that occurs. When we talk about vertebrae structures, now, this is extremely important, because when we talk about bone markings, this is how you're going to get a good idea of the differentiation between cervical, thoracic, and lumbar. When I talk about the vertebral body, that's the anterior, where the body weight is transmitted. And so it increases in mass progressively, increasing superior to inferior direction. So what I'm trying to say to you is this: from the cervical area, the body is somewhat rounded, but it gets wider and somewhat almost oval shaped or kidney shaped as you move lower and lower, because now what it is it's handling weight above itself. So the vertebral body of the cervical vertebrae is a lot less than the thoracic, which is more, and then the lumbar is much, much more. You have also a vertebral arch. This is a posterior structure that protects the spinal cord. It's also referred to in that space that's occupying, being protected by the vertebral arch. It's called the vertebral foramen. And it forms the vertebral canal that consists of a lamina and a pedicle. We'll get into that in a minute. The body processes, you have the spinal process, which projects posteriorly, so in other words, downward from the union of the laminae, and it's an attachment site for muscles, for your back muscles, basically. The transverse process, though, there's one on each side, and it projects laterally from the union of a pedicle and a lamina. The inferior articular process, there's one on each side, so there's total 2. They project inferiorly from each pedicle. There is also a superior articular process, one on each side, that projects superiorly from each pedicle. When we talk about vertebral structures also, we have to consider the articular processes meet with the synovial joint. This will provide to allow for motion between each vertebrae. What holds everything together in part is the vertebral ligaments, which provide stability of the joints between the adjacent vertebrae. The intervertebral foramina, these are the openings which allow spinal nerves to exit the vertebral canal, which are going to come out on the sides. The intervertebral discs separate vertebrae. They're composed of fibrocartilage. Okay, now this is the discs now. And this is where all the weight's going to be, between these vertebrae bodies. Now, the interesting thing is this is absent from the first and second vertebral vertebrae, and between the fused vertebrae of the sacrum and the cocci. So let's go over this. This is a nice comparative chart that I encourage you to review and, if almost, to memorize. We have the articular processes here and here. We have the spinous process out here. We have the vertebral body here. We have the vertebral arch here, and of course we've got the vertebral foramina here. Okay, notice how we have the location, neck, chest, inferior portion of the back. Notice how the vertebral body goes from small to medium to eventually massive, and we'll see this in the next diagram. Now, the superior articulation process meets up with the inferior articular faucet. All right, excuse me, the anterior articular process. You're going to have also these gaps here where spinal nerves come out. Okay. You have the superior articular faucet here, which meets up with the inferior articular faucet down here. I'm sorry. Now these are, you can tell from this image, this is probably a lumbar because it's wide, large, kidney-shaped almost. Notice also that as we get farther down the vertebrae, the vertebral foramen begins to shrink because you have less and less of the spinal nerves occupying that space. The spinous process is large and wide here, and that's why I would think that this would be not thoracic, but more lumbar. Okay, here's the vertebral body. Here's the pedicle. Okay, and in that space, you can see it's kind of like a space there. You're going to have the spinal nerves come out. Here's the arrangement to help you. You see this gap, and it's kind of like that cut through everything here. So you have the vertebral body, the intervertebral discs here, here, and here. You have the intervertebral foramen, which is where the spinal cord would go through. And what you have is an attachment. The superior part here, articular process, attaches to the inferior one here. The superior here attaches to the inferior part here. It's extremely important that you understand that the articulation faucets, that they meet so that you can have flexibility, but at the same time maintain structure of the spinal cord. Let's also look at some of the disorders of the spine for a minute: kyphosis, lordosis, and scoliosis. Kyphosis is an exaggerated thoracic curvature, giving the individual hunchback appearance, otherwise referred to as a dowager's hump. It's very common with the elderly females with osteoporosis because usually one or several of the vertebral bodies will begin to crumble and will fracture and cause somewhat of a kink, as you could see. Here, this is more the hunchback appearance you see, and this is in a child. But you can also see as this pinching is occurring, how we're having pressure put down on the main spinal cord, and thereby it can interfere with sensory input and motor input inferior to where the pinching is occurring. Lordosis, this is exaggerated lumbar curvature and results in a sway back appearance. Scoliosis is an abnormal lateral deviation of the vertebral column. To give you better approaches of this is kyphosis. This is a scoliosis, and if you draw a line right here, you can see how this sway back occurs. And then we have the lordosis, okay? And literally, it's kind of pushing, and will push the lower part of the abdomen almost outward, okay? So here's a kyphotic spine, here's a normal spine, okay? So it's an exaggeration of some of the curvatures that exist. Now, this is where I do some comparison here and also bring up the critical vertebrae that you really need to know, cold, hard, fast. First off, cervical vertebrae, C1, C2, big and important. The transverse foramen are for the passage of blood vessels. 3rd to 6th vertebrae, the spinous is short, spinous process. And it's interesting because it's bifurcated. It's kind of like split at the end out in two. C7, the vertebral prominence, has a distinctive long and prominent spinous process. It does not bifurcate, but it's palatable from the skin surface, so you can feel it back there. The function is to support the skull for the cervical vertebrae, enabling the head movements back and forth and from side to side, as well as protecting the spinal cord. The two key ones you need to really know, and I really emphasize this in your reviews, C1 is Atlas. Now, if you've ever seen the mythological character of the Atlas, he's kind of holding up that big globe. The Atlas is a ring-like, has a short anterior arch and a long posterior arch. The inferior articular faucets articulate with the occipital condyles, forms what's called the atlanto-occipital joint. allows for you basically making the yes movement up and down with the head. The transverse ligament holds the dens of the axis. Now, this comes and forms an unusual arrangement here with C2. C2 is called the axis. It has a peg-like dens. This is extending superior from the body and forms the atlanto-axial joint. And it allows for the no, or rotating the head motion of the head. Here's the transverse ligament here. This is atlas, this is axis. From axis has the dens, the otherwise known as odontal process. So, in other words, on these articulation faucets right here, this is where the skull would sit. But what you don't see is really yet a vertebral body of any significance here on C1. C2, you begin to see something. Notice here that you're going to have the posterior arch of the atlas here. And again, what stabilizes everything is that transverse ligament. So there's no basically bone around here. You will notice also as you move further down several things for the cervical vertebrae. The vertebral body here, the transverse side to side foramen. This is where blood vessels will come up through major supplies to the brain for blood. The costal processes here and here. And you will also notice the vertebral arch, the vertebral foramen. But notice that the spinous process is bifid, meaning it's split or forked. This is what you're going to get from C1, C2, C3, C4, C5, C6. Then you get the vertebral prominence, and that's really also the marker for the end of the cervical vertebrae. Okay. Thoracic vertebrae have articulations with 12 pairs of ribs. The thoracic vertebrae are typically heart-shaped body. Foramen is circular. The spinous process projects inferiorly, so downward. The costal faucets, superior and inferior, they also have articulation sites for synovial joints with the ribs. So notice somewhat of a heart shape here, the vertebral body, transverse process here, here the spinous process. Notice the spinous process points downward. So when you get into this, they're pointing downward. This is a major attachment site for ligaments, for tendons, and for the back muscles, okay? You're going to have an inferior costal faucet here, superior costal faucet here, transverse costal faucet here, okay? Transverse process here, okay? Now, we get to the lumbar, remember the 5. Lumbar vertebrae are located in the lower back between the thorax and the pelvis, largest individual vertebrae and support the greatest amount of body weight. Secondary curvature is special adaptation for bipedal locomotion, basically saying, why are we able to walk with just 2 feet as opposed to a dog with 4 feet? No, that's because you have this curvature that allows you to stand upright. Vertebral body is large and oval or kidney shaped. The spinous process is short, paddle-shaped, and projects posteriorly. The transverse process is long and slender. So let's take a look at this. Vertebral process, vertebral foramen here, kind of thinning out. Spinous process out and almost like a paddle, okay, or a keel, a rudder that you would see on a ship. Superior articular process here, transverse process here. This is the pedicle. Pedicle's thicker, okay? You have the lamina here, the transverse process here and here. Notice 1, 2, 3, 4, 5, and then we get to the sacrum. Sacrum develops as 5 separate vertebrae. By age 16 to 18 and ending by age 20, these vertebrae fuse together. The structures are interior. And what you're going to see, now the structures that are both interior and posterior, but we'll deal with the anterior first. Transverse lines, there are 4 of them. Areas of fusion between the original sacral vertebrae. The sacral promontory is an anterior margin of the superior surface, that's the base, and it's an important landmark for obstetric pelvic measurements. The apex, this is the inferior end of the sacrum. The sacral foramina, this is the openings through which sacral nerves pass to reach the peripheral structures. The ala, which is a word for wing, on each side of the base provides attachments for muscles. On the posterior side, we have the medial sacral crest. That's a central body ridge. It's formed by fusion of the spinal processes. Okay. The lateral sacral crest is a fusion. It marks the fusion of the transverse processes. Lateral sacral crests are enlarged. They're thickened to transmit weight of the upper body to the ilium and the lower limbs. The ilium are the beginning of the hip bones, as we would call them. The sacral canal is continuous of the vertebral canal. The auricular surface articulates with the pelvic girdle to form the sacroiliac joint. Now we get into the coccyx. The coccygeal corona are rudimentary, the superior pair of articular processes of the coccygeal vertebrae. They project upward and articulate with the cornu of the sacrum, and on either side complete the foramen of the transmission of the posterior division of the fifth sacral nerve. The coccyx is the site of attachment of tendons, ligaments, and muscles. It is, for example, it is the insertion point of some of the muscles of the pelvic floor. And so you can see this here. Here's your sacral promontory. This is the anterior view. Notice that you've got the sacral foramina here, the ala, the apex. We have the coccyx. Notice that it's really almost like, here's somebody that said, I broke my tailbone. They just have to be careful because these little parts will, from time to time, break. There is an attachment site here, which meets up with the sacral cornu here, and this is the coccygeal cornu here. You have, this is all posterior view now. Now you'll have the sacral hiatus here, the medial sacral crest, the superior articular process, the sacral tuberosities here, the lateral sacral crest here, the auricular surface right here and here. Okay, so these are tuberosities. These are all going to be attachment sites. Now we move back to the thoracic cage and review several important bones. We're almost done. Let's talk about the sternum first. It consists of the manubrium, which is a broad superior segment. It has a little notch in it called the jugular notch, which is also referred to as the suprasternal notch at the superior margin. It is in this area that the clavicle is attached to the manubrium. Now the clavicles, keep in mind, is part of the support framework for the upper limbs. We'll get more into that the next lab. The body is the elongated middle portion and articulates with the second and up to the seventh pair of ribs. The xiphoid process is the smallest part. It's cartilaginous well into adulthood. We have several joints of the sternum. The sternal angle is between the manubrium and the body, and the second pair of ribs attaches to this site. Now, we're going to get into the ribs and come back to the images, but I want you to be clear on some of these points. First off, I'm not going to necessarily just give you a picture of a rib and say, is that 1 through 10, or etc. But you do need to know that there are different sets of ribs. Ribs 1 through 7 are called vertebrosternal ribs. The costal cartilages directly attach from the rib to the sternum. Straight out attachment. Ribs 8 through 10 are called vertebrochondral ribs. The costal cartilages are connected to one another, so they sort of fuse together, and then they're attached to the sternum via the costal cartilage of rib 7. Okay. Ribs 11 and 12, these are called floating ribs. They have no connection to the sternum at all. Ribs that protect vital organs, heart, lung, and to a lesser degree the kidneys. Okay, heart and lungs, that's relatively straightforward. You can see from 1 through maybe 10 that they play a role. But when we talk kidneys, we're mostly talking from behind And that's with the ribs 11 and 12. Now, the ribs articulate with two vertebrae, the superior vertebrae, the inferior one, and also to the intervertebral disc. Now, when I say articulate, they come in contact with, so you have this joint effect. For example, rib 5 attaches to T5 and T4 and the intervertebral disc, except for ribs 8 through 12. Then it's interesting. Only one rib articulation on the superior costal side of each vertebrae. So, to clarify, 1 through 7, 2 attachments. 8 through 12, 1 attachment. Okay? Intercostal space, this is the spaces between the ribs occupied by intercostal muscles. These are essential for respiration. Both the internal and external intercostal muscles play a key role. We'll get into that in A and P2 for respiration. Here is the jugular notch, okay? This is the manubrium, this is the body, and this is the xiphoid process. This is very important you get this down. Whenever you've been trained with how to do a Heimlich maneuver, one of the big issues is you got to get down on the belly button, go a little bit up, and then push inward. You got to push inward because you're going to be putting pressure on the diaphragm. You never get too close to the xiphoid process. The same thing occurs when you're doing compressions in CPR. You want to put the pressure on the bone, not on this. If you do, you break it. If you break it, there is the risk that this is going to lacerate the liver. And then you've got a whole terrible bailiwick of problems, okay? If you look at the ribs here, 1, 2, 3, 4, 5, I believe I did miss something here, but it's basically 1, 2, 3, 4, 5, 6, 7, bing. All of these have direct connections via the cartilage, okay, to sternum. You got 8, 9, 10. They seem to be attached kind of loosely to this fused cartilage that eventually attaches through 7 to the tip here, almost near the xiphoid process. Now keep in mind, there's a joint here, there's a joint here. There's also the joints here and here that are going to be where you have the clavicles attach. Okay? So, ribs 1 through 7, vertebral sternal ribs, true ribs. Vertebral chondral ribs, 8 through 10. They used to be called, and sometimes you'll see in other texts, false ribs. Then the vertebral ribs down here, 11 through 12, they're also called floating ribs. Okay? So you can see how this is all arranged. Rib anatomy, I want to give you this. You need to differentiate between the vertebral end and the sternal end. It's not that I'm going to ask you again, is this rib 1 or 2 or 3? Well, it could be 1, it could be also 2. But what's the difference between the vertebral end and the sternal end? Remember, the sternal end is going to be attached basically to some of the cartilage, and eventually that's going to be attached to the sternum. The vertebral end has some unique structural developments that allow for this flexibility, but a joint at the vertebrae. So let's look at this. Vertebral end has head, which articulates with the body of the numerically corresponding thoracic vertebrae. Okay? Intervertebral disc and the body of the superior vertebrae. The tubercle, which articulates to the transverse process of the numerically corresponding thoracic vertebrae. Numerically corresponding, what are we talking about? If you have rib 2, it's going to be articulating, forming a joint with the corresponding thoracic vertebrae. So it would be attached and interactive with T2. Okay, thoracic vertebrae. The neck, this is the short length of bone between the neck and the tubercle. On the sternal end, you have a shaft, which is the body. That's the main part of the rib. The angle of the rib, this is the site of the rib shaft curvature. It's kind of like an angle, and it's anteriorly and inferiorly towards the sternum. The costal groove runs along the inferior border of the shaft, and this is the pathway for arteries, veins, and nerves. Okay, so what am I talking about? Here is the side that would attach to the vertebrae. Here, and you can tell it's kind of like a blunt cutoff here. This is the shaft. This would be attaching to costal cartilage and then eventually to the sternum. Okay, so as you can see here, you have this attachment. The tubercle fossa of the rib articulates with the transverse costal fossa of the inferior vertebrae. So it would be down below the next vertebrae down. This is going to attach. The superior articular fossa of the rib articulates with the superior vertebrae right here. And the inferior articular fossa of the rib articulates with the superior costal fossa of the vertebrae. The main point here is, as we said, from 1 through 7, we're going to get basically ribs that will have 2 articulations to the different vertebrae. And then we go below that, we just have 1. Okay? Notice the costal groove here. This is where you're going to see blood vessels, nerves passing around because there would be muscles coming down from this, the intercostal muscles. Okay? This is the tubercle part, this is the neck, this is the articulation fossa on the head. Now the head, this whole area here may also be called the capitulum. Okay? Moving on. If you get confused, here's a way to look at this. This is another diagram I pulled out. I like to try to see if I can find other means to help you. This is a thoracic vertebrae, T4. Notice that its spinous process is long, but it's pointed inferiorly, downward. T5, same thing. What are we going to have? We're going to have the superior costal fossa on T5. It will also meet up with the inferior costal fossa of T4. It will also have a transverse costal fossa of T5. Okay? Here's the costal cartilage, here's rib 5. So we're pretty much done here. Now here's what I encourage you to do. Review exercise 7.6 to 7.14 in your text. Complete the pages. Again, repetition is not going to be harmful to you. Just go through all of the section for exercise 7. That'll give you a good review. You hand those sheets in. They must be completed by 5 p.m. on Friday this week. Review all the bone models. Now, in this case, the best way to do the bone models is what I would encourage you to do is look at the videos. There are some people who are going to take bone models and go through them bit by bit, bone marking by bone marking, the skull, the vertebrae, etc. That's where you're really going to do well, okay? Just as if you were in a lab and you were doing it yourself, or you were in a lab and I was doing it for you, okay? I encourage you to really take time to go over the lab videos. Now, also, it may help you to start reviewing some of the manual reading, in other words, in SACRUM, for exercises 8 and 9, which cover the appendicular skeleton and articulations, which we'll do in the next lab. Alrighty? And have a good day.